Hello, everyone, and welcome back. Um, we are one chapter away from the end of this course, which is amazing because to me, it feels like this has been going on for many, many weeks now, but it also feels like this semester is going by fast. So, I don't know, time is playing tricks with my mind, probably yours too, who knows. Um, I am going to present this last chapter in two lectures. We are going to come to the culminating chapter, of course. A lot of people, when they think of um, psychology, the word psychology, you think of the disorders, right? So it's therapy, it's thinking and remembering and learning. But for most people, on the first day of class, if you think of psychology, you think of things that you see in this picture. You think of anxiety, you think of addiction, schizophrenia, PTSD, depression, bipolar, OCD, ADHD. There's a lot um, to uncover here. This is Psych 1, so we're just going to skim the surface. We're going to concentrate on some more than others and um, try to make it a little easy on you when we go into the last final exam because there's 3 chapters instead of 2. So um, I will talk about psychological disorders, and then in the second and final lecture, I will go into depressive disorders and bipolar as well as schizophrenia. I will give a little bit of background at the end of this lecture on some of the anxiety disorders and sort of what characterizes them, but we're not going to go into them too specifically. Um, I will, of course, add some links and some videos, videos on schizophrenia as well, um, and enjoy. So, when we talk about psychological disorders, a psychological disorder, according to both psychologists and psychiatrists, is defined as having a disorder that is marked by a clinically significant disturbance in an individual's cognition, so their thought processes, emotional regulation, or inability to regulate your emotions, or, of course, in your behavior. And that was the most updated version from the American Psychological Association in 2013. Basically, what they mean is any sort of disturbed or dysfunctional thoughts, emotions, or behaviors that are what we call or your behaviors are outlandish and um, disturbed and not allowing you to live your normal everyday life. I also usually ask at this point what the difference between a psychologist and a psychiatrist is. At least, 1 or 2 people in class usually know. um, but just in case you don't, a psychologist and a psychiatrist can do therapy for you, make recommendations, but only a psychiatrist um, who has a medical degree, MD, can actually prescribe medication. Psychologists can't prescribe medication, but psychiatrists can. That's the big difference. So, looking at therapy and trying to bring back everything that we've talked about in this course together, um, from a historical perspective, mental health was not a thing until psychology came along, until Freud really, started the market for clinical mental problems being separate from physical problems. Back in the day, again, doctors would laugh you out of the office before the 1800s. I'm sorry, before the 1900s. And earlier than that, any sort of disturbances in your behavior were either basically demons or you were a witch. So a lot of times it has been, even though we don't have recorded history for it, um, and people were thought to be possessed by demons or evil spirits. So through the ages, psychologically disordered people have received very brutal treatments. If you're not like us, if you're not with us, you're against us, you're different from us, right? Discrimination has been a thing for many, many, many generations and thousands of years, really. So people have received brutal treatments, including this skull that was dug up and discovered, where you see two holes in the head. Now, this was a believed to be an attempt for a cure for this patient. So back in the day, this is the Stone Age time. If this person was possessed by evil spirits, there's only one way that those spirits that are trapped inside your head can get out, and that would be to drill holes in the top of the skull to allow for these evil spirits to escape, kind of like opening your window for a fly or a moth to fly out. So drilling skull holes were probably an attempt to release these evil spirits. This was a practice called trephination, as you can see right here, trephination. And it's an attempt to cure those with mental disorders. So the question I have for you then is, do you think the patient survived the cure? Obviously, this was way before we had antiseptic and things like that. So this was the only type of surgery really that was done in the Stone Age. My thoughts on this are, yeah, definitely not. The patient definitely did not survive the cure, but I believe that the sort of idea behind it is, well, the person may have died, but the evil spirits left as well. So, kind of at least it's one version of a win. So when we talk about psychological disorders, again, we're talking about from pretty much the late 1800s to now. In the 1800s, as I have already talked about over and over again, our search for mental disorders had to have a physical cause before Freud came around. To be able to cure any treatment, mental or physical, you had to find the physical problem, which was okay for some things. So some STIs like syphilis, which affects the brain, is based on an infection. So it did come from a physical cause, in this case, right, sexual activity. But when you're just feeling depressed or anxious or things like that, again, doctors would say, get out if you don't have a physical cause for it. We're not worried about, we can help depression caused by chronic pain all the time, but not depression that's not caused by something physical. So in this case, mental illness was diagnosed on the basis of symptoms and treated, now I should say, is diagnosed on the basis of our symptoms and treated through therapy. Sometimes it's treated also with, of course, medication that is designed to level off your chemical imbalances, so to speak. So credibility has been gained from recent research over the last, 40 years or so, that shows that genetically influenced brain abnormalities, so genetic disorders, and abnormalities in brain structure and biochemistry, so head trauma, things like that, shows that in addition to feeling or seeing the symptoms clinically, that there may be problems with people's levels chemically, biochemically. Neurotransmitter levels, aggression is high, maybe it's testosterone levels, hormone levels, right? Things like that. So, of course, throughout this class, throughout psychology, we look at this sort of three-headed approach, the biopsychosocial approach. The medical model, of course, tends to lean heavier towards biological, and as do I. So it's this, the biopsychosocial approach is saying, let's look at it from all three angles, right? Therapy is going to help more with the social and the psychological symptoms, and medication, of course, is going to help the biological side to try to level you off. So the biopsychosocial approach, as we've always looked at it throughout this course, is the general approach that shows that biological, psychological, and social cultural factors are all playing a significant role in human functioning in the context of disease or illness. We talked about this at the very beginning, right? Now we're coming back full circle. The biological would be some sort of genetic predisposition or maybe lower levels of serotonin that would lead to a depression diagnosis. Psychological, of course, being stuck in a pandemic, having lost your job, or not being able to reach out to your friends, right? So that's psychological as well as social cultural. You can't be with those that you want to be with. And so all of these things can play a role in people having feelings of depression or anxiety or things like that, with the uncertainty in the air. We also use this idea called epigenetics that understands or informs our understanding of disorders. So most of these disorders, with the exception of a very few, or maybe even just a couple of rare ones, um, Huntington's disease, if you ever watched House, Huntington's disease was what 13 had in her family. That type of disorder is only um, one gene that seems to be the cause of that. But most everything else, you'll see a lot of overlap between anxiety and depression, between eating disorders and depression and anxiety, and things like OCD. There's a lot of overlap because a lot of the same structures and a lot of the same chemicals are sort of sharing this circuit, or sharing these things. There's a lot of symptoms that look alike. So we have to be very careful in how we diagnose. So this idea of epigenetics lets us know that in certain things that there's many genes that are involved. Some may be overflowing or upregulating. Some may be declining or downregulating. Some may turn on or off based on others. And so this idea of epigenetics is just the idea that one gene, it's like a domino effect. One gene can turn on something, can turn off something, can make something increase, decrease, right? And that sort of makes this whole thing go out of whack. So multiple symptoms, multiple brain structures involved, multiple sets of chemicals, maybe, right? That's all from this, we can see in this biopsychosocial approach. So again, looking at the biopsychosocial approach, what are the factors involved? Well, for biological, obviously evolving genes, evolving brain structure, evolving everything over millions of years, individual genes themselves, and genes that combine together, and your brain structure and chemistry. This also includes, any sort of predisposition for genetics. When we talk about schizophrenia later on in the next lecture, I'm going to talk about how it is, you have to have the genetic underpinnings in order to get it. But usually what throws it out of whack and sets it in motion is some sort of environmental trigger. So you need the environment to trigger it, some sort of stress response or traumatic response or something, as I'll talk about. But you have to have the genetics for it. If you don't have the genes that lead to schizophrenia, you'll never get it. Psychological influences, stresses, traumas, this idea called learned helplessness, where basically you feel that everything that you do or try to do doesn't work. And so it's this learned idea of, I'm just going to say forget it because it's never going to work anyway. And then, of course, as we talked about in the memory chapter, mood-related perceptions and mood-related memories. If you're in a depressed, bad mood, you're only going to remember other things from being in that mood. At least, those are the first ones that'll come to mind and the first perception. So if you're already in a negative place, then everything around you is going to be negative, and the memories you have are going to be negative, and it just leads to this problem. It's like being stuck in a loop, as we'll talk about. Social cultural influences, of course, your role in society. That could have to do with socioeconomic status. That could have to do with whether or not you have a job right now, and things like that. Expectations of what people are supposed to do. There's a lot of people that think that they have to have a normal routine down, and well, it's 2 months in and we should already know what we're doing. And guess what? We're learning this new temporary way of life on the fly, right? But parents, sometimes families, cultures have expectations of people in society, and are you there? Do you fit in with that? As well as the definitions of normality and disorder. A lot of people get made fun of or bullied or shamed for certain things. And as we talked about with this, when you guys are taking this implicit association test, sometimes it's automatic. People mislabel things. Society, right? Being labeled in society is really bad or can have really bad consequences, as we talked about. And so all of these three levels can lead to feelings of anxiety, of depression, can lead to this disorder. It's not just one or the other, it's all three. So when we get into this idea of psychological disorders, right, one of the things that we try to do, or that clinicians try to do, therapists, psychologists, and psychiatrists, is to try to figure out what the maladaptive, what the problems are that people are reporting. So they go and see a professional and they say, I have trouble sleeping, I have trouble eating, I have this, that, nothing gives me pleasure anymore, everything is just kind of lame, blah, blah, blah. So what the professional would do is to try and take the symptoms and look them up. We have reference books. One of them I'm about to talk about called the DSM-5. And we try to diagnose into a classification. So psychiatry and psychology both, psychiatry of course being medication included, tries to figure out where these symptoms best fall in line. Like I said, there's a lot of times where symptoms overlap for different disorders. So trying to be as specific as possible to try to get a diagnosis. Now people always wonder, why is it a good idea to get a diagnosis? Why do we want to know if it's this or if it's that? Because different treatments are encouraged or suggested for different disorders. If it's anxiety, that's one thing. If it's depression, that's a different disorder. So the therapies might be different for those. The medication that might be prescribed would be different for those. So the reason why we try to classify into a more specific diagnosis is to be able to predict the disorder's future course. Is this going to get worse? Is it going to get better? Do we know how long it may last? Will it help itself, or do we need more? Suggesting the appropriate treatment. We need to know the appropriate way to handle this. Is it cognitive behavioral therapy? Is it exposure therapy? What type of therapy do you want? And what type of biological problem could it be? Schizophrenia has to do with dopamine. So one of the treatments is a dopamine antagonist because there's too much. If it's depression, we usually use those SSRIs to bring up serotonin levels. So we need to know the appropriate treatment biologically and the appropriate treatment cognitively, behaviorally. And of course, maybe it falls somewhere in between and we've never seen something like this before. So what it would do is prompt a professional to say, do we know enough about this? Is this something new? Is this something that we need to revisit? So it prompts research into its causes and maybe more into treatments that may be more effective in the future. So welcome to this idea of where most mental health professionals get their diagnoses from, where they classify them. There has to be some sort of book or glossary, right, or manual that has a list of these disorders. And this is true. Welcome to the DSM-5. DSM stands for the Diagnostic and Statistical Manual of Mental Disorders, and it is put out by the APA, or the American Psychiatric Association, which again in the US is sort of the governing body of what goes on. When you write research papers, if you guys go on to a ELAC career in being a psych major, you'll take Psych 92 most likely, which is research methods. You'll hear the APA style manual, how to write an APA style paper. We're not worrying about this so much in this class, but this is where it comes from. This is the 5th edition, so you can see that it's changed a lot over the years. We know that textbooks have newer editions. So why would the DSM have newer editions, right? The 5th edition here. Well, we know that it describes disorders, it estimates their occurrence, and because we're always doing new research, sometimes the way that we label things changes. Sometimes we get new diagnoses, or we realize the way that we labeled things in the older days, now that we have better research, better technology, more research, maybe not necessarily better, then we can pinpoint things. Maybe we weren't specific enough here, maybe we were too specific here, maybe we said you either have it or don't, and now we see it as more of a sliding scale or a spectrum. So looking at some of these changes, right, over time, over years with different research, we can find that some of the things we've labeled differently. So it used to be you either had autism or you didn't. There was no real distinction between low functioning and high functioning autism. And here we see autism spectrum disorder. So now it's sort of on, like, again, on a spectrum or a sliding scale from low functioning to high functioning, which is something that we call Asperger's. Um, and you may have seen the show The Good Doctor. So Dr. Sean Murphy is a character, fictional character, based on a Korean show that suffers from savant disorder and from Asperger's, which is the high functioning side of autism, but you can still see a lot of the deficits there. The intellectual disability used to be called, just things like dyslexia or other types of learning disabilities. Now they're called intellectual disabilities, and again, they're sort of lumped together a little more. We have new or altered diagnoses. There are stages of depression or mood disorders, and there used to be, right, little ones like, if it's not full-blown depression, it was called something like dysthymia. Here, this is one of these sort of depressive type disorders is labeled as have feelings of depression or melancholy or things like that for about 2 weeks is what was um, originally the way that it was written in the DSM. Anything more than 2 weeks, unless maybe it was a spouse or something that you depended on, is more than just due to bereavement. When my grandmother died, my only ever battle with depression, that would be diagnosed clinically, would have been right after my grandmother died, because I felt like she was the closest person to me. She was my person, and I was 13 when she passed away, and that lasted for much longer than a 2-week period, right? I lost my guiding person. So nowadays I would have been considered prolonged bereavement depression, because it wasn't something that was brought on specifically by that. And now they have a sort of a label for it, a diagnosis for it, where before it wouldn't have been categorized like that because it wasn't there. Some of these are more controversial. And then there are things that we didn't know about in the past, right? If you ever hear your parents or grandparents' generation going, some of these things aren't real, we didn't hear about them when I was a kid. We didn't have any ADD or ADHD. Well, yeah, it hadn't been discovered yet. They didn't know what it was necessarily, or which ways that it can be controlled, until they had the proper research on it. So new categories, we see that an offshoot of obsessive compulsive disorder is now called hoarding disorder. There's a show on TLC about hoarding. This is people who collect stuff and literally mentally can't let it go. Like, it's a part of them. It is painful to them mentally, and sometimes even physically painful, to have to try and let go of some of their stuff. And this is a problem. So this is a type of sort of an offshoot, but gets its own diagnosis as an offshoot of obsessive compulsive disorder. And when we talk about eating disorders, over the history of the diagnosis of eating disorders, we talk about the ones that are, that go with, body, what's called body dysmorphia, where you're unhappy with the way you look or things like that. So a lot of times it has to do with the trying to lose weight. So the things like anorexia and bulimia, anorexia being the starving disease, where you're restricting calories, maybe excessively exercising as well. Some people do that. Whereas bulimia is one where you eat about 2 to 3 times the size of a meal and then throw it all up before your body can really absorb everything. Obviously, anorexia causes more rapid and greater weight loss. But bulimia and anorexia used to be, those were the eating disorders. People didn't think about, what about if you're eating and eating and eating and not throwing it up, and you're gaining weight and not losing weight? That's still a disorder. That's still wrestling with loss of control. That could be considered as an addiction. So binge eating disorder had to be added later on, because we're not just looking at it through the lens of losing weight. What about people who just turn to food? In that case, they're dependent on it, right? So it could be related to addiction. It could be just coping mechanism, but that it has to be there. Just like in the chapter on sleep, we talked about that most people um, suffer from maybe like sleepwalking or sleep talking, but one of the newer ones as well is sleep eating, because that has been shown in some patients, right? So are there criticisms of the DSM? Of course. Certain things, maybe people disagree about the way that things are labeled, or that things are even a diagnosis. Um, Things like, and sometimes the field tests or the research that's prompted into some of these disorders does not do as well as people hoped it would do. And that's going to happen. That's the nature of research, is a lot of times it's not going to work. So we see things like field trials for antisocial personality disorder, or even the more popular, more widely diagnosed generalized anxiety disorder, did really poorly on some of these research field tests. And one of the biggest criticisms that I've already mentioned is that um, the DSM contributes to pathologizing in everyday life. And I always, at this point in class, ask people if they've ever seen the show Community. And I know that a lot of you guys are just out of high school, so maybe when Community was on, it wasn't your thing, or it was, not something your parents let you watch. But now it's on Netflix, and so I would definitely recommend binging it, because it's an amazingly funny show about students at a community college. And It's kind of where Donald Glover, aka Childish Gambino, got his start. So he's hilarious. But one of the characters in the show, her name is Britta, and I think it was season 2, she took a Psych 1 class. And remember, at the beginning of class, I told you guys that you don't want to, after one Psych 1 class, think that you can start, diagnosing people. I definitely am still sticking with that statement, especially now that more than half the class is online. Um, so one of the criticisms is that the DSM contributes to pathologizing in everyday life. And the reason I brought up the show Community is because Britta, the white blonde girl, her character, after taking one Psych 1 class, thought she was like a professional and just started diagnosing people and all of this. And although it was hilarious on the show, remember, if we're labeling people in real life, you're labeled as crazy, you're labeled as damaged, you're labeled as a jailbird, right? This could really have bad consequences in the real world. Because, as it says, system labels are society's value judgments. So people think, if you're labeled once as crazy, maybe it was a temporary thing, maybe you had gone to therapy for it, but you may always be seen as crazy to some people in that case, right? And that's a bad way to go about it. So remember to try to limit our automatic responses and try to make them conscious. And also, we don't want to use this book to try to analyze people, or, right? Sometimes you may even hear people say, I hear this all the time, oh, you have a PhD in psychology? Oh, well, I don't want you psychoanalyzing me. And I'm like, I don't do that, and I don't like Freud's way of doing things. So you're good there. But of course, there's also many benefits to this. It helps for a general, universal way that people can diagnose things, categorize things, put people into those categories to get the right treatments and the right help, right medications. And of course, it helps mental health professionals communicate with one another, and to try to give direction, specific direction for their research for more things, right? So that the DSM-6, whenever it comes out, we'll have an even better idea of what works, what doesn't work, how we should categorize this. And this is a global thing. I mean, the DSM is mostly governed by the APA, which is US, but it also helps to coordinate with other countries and everything. So, looking at some of these things, one of the things I just brought up about a couple minutes ago was sometimes older people saying, oh, well, newer diagnoses weren't around when I was a kid. Well, that doesn't mean people didn't have them. It just means we didn't have a name for them yet or a way to treat them because we weren't sure what they were. One of the biggest problems probably that you'll find in uh, this sort of subject or topic is the fact that sometimes we may be too quick to diagnose things, as in older times, because mental health had such a really bad stigma to it. People were not likely to go get help or to go get diagnosed because they didn't want a label and they didn't want people to know that they were suffering from something. Nowadays, we might be going too far the opposite direction, which is it's not the best thing, but it's not necessarily a bad thing. I'd rather have somebody be proactive in a diagnosis and trying to get help than to be, to not go at all. But what we see here from these, looking at ADD and ADHD, and if you don't know the difference, ADD is just attention deficit disorder. ADHD means they're also hyperactive. So it's attention deficit and hyperactivity disorder. And what we see in the numbers, right, looking, and if you ever wondered for these are called epidemiological estimates, meaning what percentage of the population in a given time has this. Normally, they give these surveys out and they ask people, within the last 12 months, have you been diagnosed? So these numbers like 11%, 2.5%, and blah, 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 tend to come from surveys that ask, have you been diagnosed with this in the last year, within the last year, the last 12 months. That number jumps up a lot higher when you ask if people have ever over their lifetime been diagnosed with a disorder. Like I said, after my grandmother died, I wouldn't say that I have the genetics for depression. I wouldn't say that I've ever been diagnosed other than, or would have been diagnosed other than that one time. So it most definitely would have led to, as a prolonged bereavement type of thing. But regardless, right, it's a diagnosis over my lifetime. So that number jumps up a lot higher. We'll get to that. So for ADD and ADHD, this is where we'd normally have a nice little discussion. So I guess this makes the lecture a little shorter because we can't. But in this case, we see that 11% of American children 4 to 17 years old receive a diagnosis of ADHD after displaying some of its symptoms: extreme inattention, the inability to focus or pay attention, hyperactive behavior, and very impulsive behavior. Impulsivity, kind of like what you'd see from somebody who was addicted to drugs, where they can't really control their behavior. Only really 2.5% of these diagnoses really have all of these symptoms. We know that the symptoms can be treated with medication and other therapies, and Ritalin is one of the main ones. Adderall is the other one. But this debate continues over whether or not these things are diagnosed too often. It's all too often actually diagnosed as a psychiatric disorder. And whether there may be a cost to the long-term use of stimulant drugs, because you're using basically legalized speed in order to get these people to focus and to settle down, which is funny because you wouldn't think giving an upper to somebody that's hyperactive would actually work, but it does in the short term. Long-term effects, we're still looking at that. We started giving medications like this in the 70s, and now we're starting to see some of the longer-term effects from people. But the problem with this, and this is where I ask you guys to give your opinion on it, but a lot of times students, say things like that maybe there are kickbacks from drug companies, and that's very true. So there's an incentive for doctors to diagnose this and prescribe medication, because the pharmaceutical companies that make it say, yeah, if you prescribe it and people take it, we'll give you a bonus for this many times. It may also be easier for parents to be looking for that. A lot of times these days, both parents work, and of course not when everybody's stuck at home, but just on a regular schedule, both parents work, the kid has to go to school. Um, and what they don't take into account is maybe just trying to run around the park for half an hour before the kid goes to school. Maybe they don't have time to do that. Maybe they don't realize it. So I like the idea that more people are proactive as opposed to not wanting to get a diagnosis and sticking their head in the sand. But for people that haven't tried this, maybe they're too quick to go to a doctor and say, fix it. Haven't really tried other things. One of those things I would just say is have them run around for 20, 30 minutes at the park before school and see if that works. And if it doesn't, and they really do need it, so it's not all of the 11% that need it, but there are some that do, right? At least 2.5% there. So yes, I believe it's overdiagnosed. Yes, I believe medication for this is overprescribed. That doesn't mean that I'm anti-medication, of course. So that's where I stick in this. And you can have this debate yourself if you'd like. One of the other big misnomers that we have in society, and this is of course led a lot by people in a governmental role, like the president and things like that, that say gun control laws are not needed. It's the mental health of these people that get guns and then shoot up schools. Um, and of course, I mean, you can make the argument that anybody that's capable of, any of these school shootings or mass shootings is definitely not mentally stable. But it gives the stigma that it's mental diagnoses that lead to this. And if you really think about it, or if you really take a dive into the research, what you find is that mental disorders want to avoid other people at most of the time. So to say that mental health or mental disorders lead to violence, that's very rare cases. There are cases where people are psychotic, having episodes of during schizophrenia, or maybe this some of these personality disorders like antisocial personality disorder and things like that. But majority of these diagnoses, even ADD, you're not really able to pay attention to one thing and focus, right? So the clinical prediction of violence is pretty unreliable. What the research overall tells us is that you are much more likely to be the victim of violence if you have a mental disorder. Look at the way that people have been treated over years. In fact, in the late 1800s, they would just chain people to the walls and to asylums. And so they're much more likely to be the target of violence than to actually be violent themselves. But that's not the narrative that this country gives. So when they do, moral and ethical questions about whether society should hold people with disorders responsible for violent actions are raised, right? A lot of people in the court system try to get away with temporary insanity, or that because or that they are mentally ill, because of course it's much better for you if you're going to get a life sentence for killing somebody, right? It's much better to do it in padded walls with medication than to go into a prison system, and you know what that is probably like, right? So what the bottom line here is that most people with disorders are nonviolent and are much more likely to be the victim than the attacker. But that's not the narrative that it gets in society today, which is infuriating to say the least, but what are you going to do, right? And then that also leads to the idea that in the jail systems, another debate that we could have in this chapter and in this for this course is people that are behind bars, right? The ones that are actually in jail. We find that about 2/3 of them have some sort of mental diagnosis. Now, whether or not that diagnosis came before or after they went to prison is also questionable, right? A lot of times, if you're stuck with no way to get out, that could lead to depression, anxiety, paranoia, thinking that somebody may try to hurt you or sexually assault you in jail and things like that, right? Those things are sometimes overblown, but are definitely real. So we don't know which way the that it goes. Are there people who have had mental issues, probably diagnosable issues, that ended up in jail? Sure. Are there people that, because they are in jail, then develop some sort of psychological disorder? Absolutely. So there's really no question, or no way of knowing how much of it was before and how much of it was due to the fact that they were imprisoned. The same can be said for poverty, right? When we see people who are homeless on the streets, and we went all the way from, nature nurture, we talked about this in uh, chapter 13 in social psych. um, we know that poverty is a risk factor. We know that our psychological disorder rates vary. Again, this is sort of in the past 12 months versus over a lifetime or something like that. And we know that poverty is a risk factor. So we know that people who live in poor conditions and have bad experiences associated with poverty can contribute to this development. If you're not able to get out of your financial situation and you're kind of stuck, you're homeless and you're in this loop where you can't clean up to get a job because you don't have clothes or money, and you can't get clothes or money because you can't get a job, right? So that could lead to a lot of anxiety, a lot of depression, and those types of diagnoses. But of course, it could be just like with the prison system. It could be based on mental illness that you can't function in normal life. You can't function in society. So some disorders like schizophrenia can drive people into poverty if they don't have family members that can take care of them. Um, they're just kind of on their own. And that can cause homelessness because they can't live a normal life or hold a job down or things like that. So in this case, we ask the same thing, right? Like with the prison system, poverty being a risk factor, which way does it go? And the answer is both, right? We have people that have been diagnosed with a mental disorder previously that can't function, family doesn't know what to do with them or can't take them, or doesn't even know that they've gone off the grid. Or being poor and living in poverty can also lead to these things. So it goes both ways. Again, looking at the percentages, these are what we call the epidemiological estimates of how often this is diagnosed in society. This is within the US. As you see on the right, this is the percentage of Americans that report selected psychological disorders within the past year. Now, this one was probably from about 8 or 9 years ago, but the amount of diagnoses in the last few years is relatively stable. Before we look at the individual numbers, by the way, if you were just to ask how many people on these surveys that are sent out every few years would answer to any of these, right? So not just a specific psychological disorder, but if you ask them within the past year, within the past 12 months of this survey, have you been diagnosed with any of these mental disorders, any of these psychological disorders? And the number you get from the people that respond is about 24 to 25%. So we're looking at a quarter of the population in any given 12 months could be suffering. Now, a lot of people are continuing to suffer from these things over time, of course. Some bouts of depression and things like that can get better. So most of these things, though, are continuing to be with you, right? But if you ask the question to people of, have you ever been diagnosed in your entire life? That number jumps from 24%, 25% up to like 45%. So it jumps way up for the percentages that people have been diagnosed. And again, I would have been diagnosed at the time with what would be now considered a prolonged bereavement type of depression. It lasted me almost 6 months before I was finally able to sort of overcome that. So that number jumps way up. But if we look at these disorders specifically throughout the time, then we can see where these instances are, how often they may occur in any given year. So looking at the anxiety disorders, and you can see that actually a lot of these qualify as anxiety disorders. And I think I'm going to go over those at the end of this lecture just a little bit, because I think we don't have the necessarily the slides for it. Yeah, it's coming up. So looking at these, generalized anxiety disorder. So we don't have the time to talk about all of these, this entire chapter, and I want to be able to give you a reasonable, manageable amount of time before the final to study this. So generalized anxiety disorder is about having nothing in particular that you're anxious about. Just in general, you always have a lot of anxiety. It could be about a number of things, and it just always seems to be there. So we call that generalized. So there's nothing specific. This is a generalized anxiety disorder, and that affects over 3% of the US population in any given year, right? 3% of the population. A lot of people have anxiety about social situations, and that one is a little more specific. Generalized could be about anything in general. Social anxiety is people that get anxiety specifically in social situations where they have to be in front of people, where they have to give a report, where they have to interact with people and things like that. And so that jumps up to almost 7% of the population. A lot of times you hear about people that have very specific, very direct things that give them anxiety and fear. People have fear of heights or fear of enclosed spaces like claustrophobia. People have fear of going outside. Sometimes that's different from social anxiety. That's just leaving your house. Some people are deathly afraid of spiders or snakes or certain specific things. Those are called phobias or specific objects or fear of specific situations. And for people that have those, they know that the anxiety is coming, and it comes directly from thinking about or contact with or exposure to one of these things. That's a phobia, and that's even higher. That's almost 9% of the population. Another offshoot of anxiety disorders is obsessive compulsive disorder, which seems to only affect about 1% of the population by its true diagnosis. Now, there's a huge stigma with this one because that term is thrown around a lot for OCD. People who have OCD or obsessive compulsive disorder, the obsessive portion of this is recurring thoughts. So a person who may wash their hands all the time, right? Their thoughts, the obsessive part is, I'm not clean, I'm not clean, I'm not clean, I'm not clean. So once they use the restroom, for whatever reason, they'll go in and wash their hands. That's the compulsive part, is the actual behavior. So the thoughts are the obsession. I'm not clean, I'm not clean, I'm not clean. And then when they're done in the restroom, they wash their hands not once, not twice, but maybe 5 to 6 to 7 times. So the obsessive part is the recurring thoughts that they can't get rid of, maladaptive. The compulsion is the actual physical thing they do. People that feel like they're not safe. I'm not safe, I'm not safe, I'm not safe. And then they'll lock their doors 4, 5, 6 times, right? Yes, it's quirky when we see things like Sheldon on Big Bang Theory. Knock, 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 penny, knock, 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 penny, knock, 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 penny. But people who don't have they have a couple of papers askew on their desk, and they feel like, oh, I need to have my papers in a perfect order, or they can't be, jagged, or things like that. And that term is thrown around, oh, you're so OCD. But OCD, right, the actual diagnosis is devastating. It's something that people can't live a normal life. It's not just like putting a couple of papers together and making sure your place is clean. It's about the thoughts that obsessively come into your head that you can't stop, and the compulsions, the behaviors that you constantly do that are affecting the way you live, right? So there's a huge stigma on that. And for people to say, oh, you're so OCD, right? It does a real disservice. And again, it goes back to that idea of labeling in society. The other type of anxiety disorder that we would see in here is a traumatic disorder. And trauma is a little bit different from anxiety, but it would be categorized as an anxiety disorder, and that would be PTSD, or post-traumatic stress disorder. Of course, different people have different genetics, and that may make it easier for some people to call something trauma when others don't, right? Just like with anxiety, a lot of times people say, that these people sweat the small stuff. So if somebody comes home and the place is a little bit of a mess and they get anxiety about it, is that actually OCD? No. But could it be attributed to anxiety, generalized anxiety, or things like that? Absolutely, right? So PTSD affects about 3.5% of the population, and that is one that was originally come up with when they saw soldiers returning from war. So it was really discovered probably during the time of the Vietnam War, when they saw a lot of people coming back and being very traumatized by it. But it doesn't have to be soldiers in war zone. We do see this with a lot of prostitutes that get sexually abused. We see this with people who survive dog bites and plane crashes and auto accidents. And, you know, it doesn't have to be catastrophic for it to register as being something traumatic for someone. Like I said, with different levels of genetics, what one person could be, could have a small episode and, you know, be chased by a dog or something, and that could be enough of a traumatic experience. For another person, it might have to be a life or death situation for it to be. But this is post-traumatic stress, and that is all of these stressful and sometimes violent outbursts based on the traumatic experience, and that it causes them to not be able to function in society. So these are all sort of in the category of anxiety disorders. What else do we see? We see schizophrenia, also about 1% of the population, 1 out of every 100 people. Schizophrenia we will talk about very specifically, especially since that's what I studied at UCLA, and watch videos based on that and talk about media's influence. ADHD, so here you see a number that's different from a few slides ago that says about 4% as opposed to 11.5 or 2.5%. But remember this, that slide from a few slides ago was talking about diagnosis of children between the ages of 4 and 17, and this is everybody in society. So even at a rate of 4.1% for ADHD, that's still most likely higher than we would see in the patients that actually have the symptoms for it, right? So that's probably also closer to 2.5% in reality. But this is the people that report it based on diagnoses and things like that. The one that we would call the most popular of them all, the one that seems to occur the most, is depressive disorders or bipolar disorder. And in case you don't know the difference, which we will go over in the next lecture, depressive disorders are sometimes called unipolar depression, because if you think of your normal level of functioning or mood, depressive would be much lower than normal on the bottom, the South Pole side of things. But bipolar patients actually cycle from the low depressive phase to a very hyperactive manic type phase, which is much higher rate of mood and activity than you normally would go. And they are kind of stuck in a roller coaster where they can't get into a normal middle level of functioning. They go straight from the North Pole of hyperactivity and mania all the way down to the South Pole, right, of depression and pit of despair. And they can't really regulate, and they don't get to sort of function in the middle. They just go from one to the other. So we'll talk about that more in the next lecture. But the last thing I wanted to show you guys in this one is that there are a number of outside factors that could be considered risk factors to make you more susceptible to a diagnosis of a psychological disorder. But the good news is there's also protective factors that play a role. I was just talking in my Psych 2 lecture on learning and memory that one of the things that older people could do to try to help themselves out and work their brain out like a muscle is to do, when they retire, do things like crossword puzzles and Sudoku and learn new things and try new things and keep those connections as strong as possible. And maybe that can protect against future cognitive problems. So let's look at some of these risk factors and some of these protective factors before we go for this lesson. Some of the risk factors that can lead to mental health problems or are risk factors for that can lead closer to a diagnosis. Things like academic failure, and thank you guys for sticking with me, birth complications. One of the biggest ones we talk about is caring for those who are chronically ill or who have a neurocognitive disorder. Caring for somebody with Alzheimer's disease, with Parkinson's disease, with some sort of terminal illness. Because guess what? Most of the time, who do you think the caregivers are? You think they're people that, nurses that can come in and do this? Sometimes, but an overwhelming majority of the time, because that gets really expensive, it's family members that never signed up for it, just for, being this person's nephew, niece, kid, grandkid. You're stuck taking care of them for better or for worse, and that can have an emotional toll on you. A lot of these people that are caregivers suffer from depression and things like that because they're kind of stuck taking care of this family member. Child abuse and neglect, of course, chronic insomnia can cause problems. We already talked about that in the sleep chapter. Chronic pain can lead to a lot of things, like especially depression. Family conflict or disorganization. Low birth weight may be a signal or a factor, because maybe a mom used alcohol or drugs, or other things. Low socioeconomic status, poverty, is a risk factor. Medical illness, of course, right, can be what we call comorbid, which means more than one diagnosis. That can definitely lead to depression and things like that. Obviously, we talk about the biological side, neurochemical imbalances, right? Low levels of serotonin, norepinephrine, higher or lower levels of dopamine, and things like that. Parental mental illness, we know that it's a genetic factor, so that's always an increased risk if you have a family member, especially a parent, that hands down your genetic material. Personal loss and bereavement, sometimes it can last longer for some than others, like I told you. Poor work skills and habits, sensory and reading disabilities, social incompetence, not being able to figure out how to function in society. Again, that's a two-way street. Is it because you can't adjust, or because there's a problem there and causing you not to be able to adjust? Stressful life events. Stress is always going to mental and physical anguish, right? Substance abuse, of course, is its own diagnosis, and traumatic experiences. But what about some of these factors that protect us? Aerobic exercise seems to help increase endorphins, get blood flowing, help with neurogenesis sometimes, and of course make the body feel better. Communities that offer empowerment, opportunity, and security. When we talked about in the last chapter about humanistic psychology, we talked about, do you have a growth promoting environment? Having a growth promoting environment, whether it's your family or your entire community, to lift you up and say, hey, we got your back, that does a lot for your mental health. Achieving economic independence, being able to afford everything on your own and not have to ask for help. Feeling like you're doing an effective job parenting. Feeling of mastery and control of your environment, like I got this, I can do this. That leads to more positive attitudes and seems to protect against mental anguish, or can protect, right? This doesn't mean that they absolutely do, but it means that they can lead to protect as opposed to be at risk. Feelings of security, literacy, the ability to read and write. Positive attachments and early bonding with people, right? We're looking to make a connection. In Maslow's hierarchy, we talked about that need to belong and love. Positive relationships with parents, between parents and children. Being able to solve problems, good problem solving skills. Resilient coping with stress and adversity. Again, that idea of positive psychology is thinking about, the ability to think about or have your thought processes glass half full instead of glass half empty. And just being able to look at the bright side of things. Right, we're in this together. It's going to end eventually, and we're going to be able to put everything back, and we're going to be great. High self-esteem we talked about in chapter 13. Actually, that was at the end of the last chapter as well. Social and work skills, proper work skills, and of course, not just the community, but especially social support from your closest family and friends. Right, so all of these things lead to potential protective factors against diagnoses of mental disorders and things like that. There are many risk factors in this world, but there are also many things that can protect us potentially against falling into a diagnosis. When we come back, I will go over the major depressive disorders, including bipolar disorder, and we will talk about schizophrenia, and that will end our lectures for the semester. So I look forward to coming back. I hope you look forward to another rousing lecture. And as always, I will talk to you soon.